and we have some topics here. So we'll go over the agenda and then the moderator will start. So Dr. Osama, when you are ready, can share the...
Yes, I'm here. Hi, everyone, and welcome for the new batch for the research, geriatric research project here this year. And the first presentation will be topic in nutrition and weight changes in older adult, presented by Dr. Jitish and Akhila. So if you are ready, you can go ahead and start your presentation.
I'm going to just share the agenda for today. So we have 4 main topics, and then we will talk about the project ideas and what we are going to do, or some updates. So the first topic will be about nutrition and weight changes as we get older. Then dental topic, followed by some sport design and some examples. And how to prepare for a poster and poster presentation. Then we will talk about projects up to date and so forth. So
I think Akhila sent a message that she had a technical problem, so we can go to the next presentation, and then we can go. She can start after that. So the next presentation will be dentition in older adult, presented by Sahar Zaki. Sahar, if you are ready, you can go ahead and start our presentation. Sahar, are you there? Hello, Sahar.
maybe we can just start with idea.
Okay, we can go for the third topic, design and selecting variables data, presented by Dr. Amro and Dr. Taysir. Dr. Amro, if you are ready, you can go ahead and start.
So I don't see Amro, I don't see Sahar.
Sheila had a technical problem. She says that she cannot get in. She had presentation on nutrition. And I talked to her like 1 hour ago to leave the meeting after 3 p.m. because I have to go to the airport. So I talked to her, but she said that she had a technical problem. And I sent her the password, and I don't know.
There are a couple of fellows that joined a meeting for the grand rounds. They're on the other side. A few of them have joined this side, but I'll just double check again. I'll be a minute.
In the meantime, we have new fellows joined later, or they did not make it for the first couple of presentation or Zoom meetings. So if And if you is new, please just introduce yourself, say hi, and we'll take it from there. Myra, you can start.
Hello.
Hello, go ahead.
Hi, how are you, everybody? My name is Mayra Mazzoni. I'm from Venezuela. A physician. I work in the area of pediatrics and psychiatry. I'm finishing my master in psychology right now. I live in West Palm Beach, Florida, and it is a pleasure to be here with you guys.
Thank you and welcome.
I think I'm the only Latina, no?
I think so.
Yeah.
Habla un poquito.
Un poquito. Okay, perfect. Whenever you guys need help in Spanish, here I am.
We'll definitely need this in the future. So thank you. Anyone else of the new fellows? Manhali, Raja, Ali, or Asma, is one of you there. All right. So when we are ready, we can talk about the next. So I'm gonna just show you guys again how to find the app and the files when we are talking about next talk or something. If you go to the app, you can just scroll down and you can find it somewhere here. And then you can download and you can present. Thank you. So I can take it from here.
Okay, I see that Amro is joining. So Amro, if you are ready, so you can start your presentation. Amro.
Hi everyone. Okay, Dr. Sama. Can I start? No
Okay.
problem.
All right, thank you.
Okay, I believe there's a problem. Some fellows facing because there's difference in the passcode. Yeah. So that's why a lot
The
of them.
passcode is 15963.
Yeah. Thank you. The word have
15963.
been correct in the group.
Yeah.
Okay. Just 1 minute.
Sure.
Is it clear?
Yes.
So slides moving, changing from one to another.
No, it's only on the objectives.
It's clear, but it's it's now start moving. Yeah, it's clear.
Okay, we can start like that, no problem.
Yeah, that's perfect.
Okay, I'm going to talk about the design and selection of the variables. Firstly, I want to thank Dr. Nader for giving me this opportunity to present this topic. The objectives of this topic is trying to make everyone familiar with the types of study design and to choose a suitable study design in order to answer your research question. Also to feel more comfortable with the clinical research process and understand the different types of variables involved in your research. Also give some examples of different research types which have been done by the fellowship teams previously. Okay, previously the research process had been mentioned in last week, starting by identification your aim and approach and objectives, going through literature review, and then determine your design, and then going through the data collection and analysis, and finally interpreted your findings. Okay, every study have different variables, so it's mandatory to define which variables your study is containing. What is a variable? We mean by variable any subject, or any characteristic that is subject to change and can have more than one value, such as age, intelligence, motivation, gender. It can also be disease, can be depression, can be medication, antipsychotic. So firstly, it's mandatory to define what variables your study is involved. These briefly the types of variables. It's divided into categorical, numerical, and categorical further divided into nominal, like an marital status, eye color, and ordinal. Ordinals from the name, it's like an order. For example, using questionnaire. Examples like good, better, best, for example, and sometimes like low, medium, and high. These ordinal categorical variables. Other type is numerical, which is subdivided into discrete and continuous. What we mean by discrete is that the main idea is relying on counting items. For example, number of children, number of items, and another example is another type of the numerical variables is continuous variable. Continuous variable, the main idea is relying on the measuring of the items, measuring it and record it and encode it in our study as measured. For example, the weight, which can be, for example, 70 kilo, 70.5. So we encode it as we measure it, and in this way, how it's different from discrete. This illustration of the different study design. It's already covered previously in the last week. This table shows some differences, with the main difference between the study design and the other, as showed here in this table, is an intervention. If intervention is clear, it's clinical trial, it is experimental. If no, it's observational, and with the different types, cross-sectional, case control, and cohort, and further differences you can see in this table. Which study design is appropriate for your research? Which one? As we mentioned previously, if intervention is clinical trial. If not, it's observational, cross-sectional, for example. If the disease is rare and the prevalence less than 5% rate, it's better to choose case control. If you are looking forward in time for a new incidence of the disease, then it's a cohort study. So from the beginning and your research question, you can choose which study design is suitable for your research. I'm going to start with the case report and case series. Case report and series, the case study research. It's descriptive researches prepared for illustrating novel, unusual, and atypical features identified in patient and medical practice. So potentially, they generate new research questions. Sometimes case reports present as a detailed report of diagnosis, treatment, and follow-up of individual patient. Case reports also contain some demographic information regarding the patient under study, for example, age, gender, and ethnic origin. Case studies involve multiple patients. Case series involve multiple patients. Both study case series and case reports are qualitative research methods and include in-depth analysis and experiential inquiries of person or group in the real-world setting. Is some advantage and disadvantage of the case report. For example, you see it's observational. It's one case to initiate the signal. You need just one case. Provide strong evidence with the multiple cases. Educational, easy to do actually, and identify rare manifestation of the disease or the drug. The disadvantage, you don't have control group, and sometimes the cases may be not generalizable on the population, and sometimes you will face selection bias in the case under study. Those are examples of case reports done by the fellowship teams. For example, this case report titled "Pain Control with Intra-Articular Steroid Injection." can reduce dementia-related mood and behavioral change in nursing home settings. The aim of the case report to highlight the possible role of the pain control using intra-articular steroid injection as a treatment option for behavioral change in nursing home residents suffering from dementia. Another example of a case report done by the fellowship team, title was "Can Steroid Joint Injection Improve Neuropsychiatric Symptoms in Patients with the Dementia?" So now it's cross-sectional. We go briefly through cross-sectional study design because it's already been covered by my colleague last week. It's also known as a prevalence study or a survey, and it is the easiest study design. The main idea is that measure the relationship of the variables in a defined population in one particular time. So both risk factors and disease outcome are observed at the same time. For example, studying the effect of overweight on the prevalence rate of diabetes. Reminder, if you this is notification, if the prevalence and incidence or incidence rate of below 5%, you don't have to choose cross-sectional study design because your number of cases would be too low to do analysis. And the better to go do for rare disease and prevalence less than 5% to do case control study. As mentioned previously, we'll start in case control with the outcome, identify sample with the condition of interest, and identify similar control group and look back to determine exposure. You cannot use this study to establish prevalence. The advantage of the case control is that you will be able to study rare disease and you can explore multiple exposures, relatively inexpensive, can calculate odd ratios, can support causation, but not prove it, and it's easy to get cases as we mentioned earlier. We'll move to cohort study, also mentioned last week, and start with identified group, determine exposure in everyone at the same time. Follow the group, determine who developed the outcome of interest, can be used to determine the prevalence. This is illustration of the process of cohort study. Also this illustration. The recruitment of the targeted group or study group must be free from the disease of interest at the beginning of the study. And one of the drawback of this study is that some people with a subclinical presentation of the disease may miss from being excluded. And this is one of the challenges of cohort study. Examples of cohort study done by the fellowship team. This is a cohort study titled Artificial Intelligence to Stratify Risk Factors in Older Patients with COVID-19. It's a retrospective cohort study. Objective was to identify the impact of common comorbidities in elderly patients with COVID-19, utilizing artificial intelligence software in predicting the hospital length of stay, ICU admission, and death. The message, as written here, the retrospective cohort study, data collected from 439 patients with a confirmed COVID-19 test admitted to the Spur Hospital, Lansing, Michigan, during the targeted period from March 2020 to October 2020. Inclusion criteria were 60-year-old and more with one or more of the following condition: diabetes, obesity, chronic disease, vitamin D deficiency, and shock. Another example of a cohort study done by the fellowship team, the effect of COVID-19 pandemic on depression and medication use on nursing home residents. As clear from the title, the objective was to study the effect of COVID-19 on depression and medication use in nursing home residents. Okay, the methodology is a retrospective study, and the data collected from CASP reports. Data collection were obtained from 3 different nursing homes facilities, and during the targeted period between March to October 2020, and the variables compared here in this study were depression and anxiety and use of antipsychotics. Team compared variable percentages at a local facility, state, and nationwide. Right now, we are going to move to the randomized controlled trials. It is a gold standard for determining associations and identify group. In this study, you identify group and randomly assign individual to the exposure. This is illustration of the experimental study, starting by the population and then inclusion criteria, applicable participant. Then you define them according to their exposure. Research. Okay, right now we are moving to talk about some research and study design which use secondary data like literature review, systemic review, and meta-analysis. The main point in literature review is that you are going to gather information from articles previously studied the topic of interest and summarize the findings. For example, this is a literature review done by the fellowship team. The title is The Positive Impact of Music on Aging Auditory Cortex and Memory. Objective: to investigate the positive effect of music on memory and the auditory cortex in all age groups. The method: 4 reviewers extract, analyze the study independently using the predefined criteria to include studies that were adult population, and multiple studies were reviewed from different study design like clinical trials, case controls, cohort and cross-sectional studies, and systemic reviews and meta-analysis conducted from 2011 to June 2021. To minimize the bias, 6 researchers verified the result. Another example of literature review study titled Vitamin D Influence on Aging Brain Function. Objective, clear from the title, to conduct a follow-up systemic review on association between low vitamin D level, cognition, and dementia. The methods at the previous one, different studies have been reviewed that talk about the vitamin D deficiency and cognitive function published between 2010 and 2021. The target population was adult worldwide. Animal models and studies on human subjects with dementia, stroke, and pre-existed condition brain tumors were excluded. Move to systemic review. It's a broader concept of literature review, summary of clinical literature. Systemic review, the critical assessment and evaluation of all research studies, published or not, that address a particular clinical issue using a predefined research strategy. The researchers use an organized method of locating, assembling, and evaluating a body of literature on a particular topic using a set of specific criteria. Systemic review typically includes description of the finding of collections of research studies. Systemic review may also include a quantitative pooling of data called meta-analysis, and this is a broader concept from systemic review. Examples of systemic review done by the fellowship team. There is a systemic review on echocardiographic findings of myocarditis after the second dose of messenger RNA COVID-19 vaccination dose. You hearing me well?
Yes.
Yes, we hear you.
Okay. The method of this systemic review was a research team reviewed studies that focus on echocardiographic findings of myocarditis after second dose of messenger RNA COVID-19 vaccination dose. There were no restriction on the study design or language. The study population includes anyone who developed myocarditis after receiving second dose messenger RNA vaccine dose anywhere in the world, regardless of age, comorbidities, or prior COVID-19 infection. Another example, a very interesting systemic review, titled Screening Dementia. screening dementia, it's time for a test guide systemic review. The objective of this systemic review was to conduct a systemic review of recent literature to provide an evidence-based screening tool guide to assist clinicians in diagnosing dementia. Method was the reviewing of English language studies published between 2010 and 2020 on 5 databases. 32 studies met the inclusion criteria. The target was the geriatric population, no constraints on the country of the study or the healthcare setting. Finally, the meta-analysis. It is the most valued study design statistical process of combining data from many different research studies. It's a broader form of systemic review, takes findings from several studies on the same subject and analyze them using standardized statistical procedures. Integrate the findings from the large body of quantitative findings to enhance understanding. And the concept of that every study is a unit of analysis. And finally, draws conclusion and detects patterns and relationships. By this, we finish my presentation. This was slides showed the link of Telegeriatric Research Fellowship Team publications. Through this link, you can see multiple publications and posters that have been presented at different conferences. Thank you.
Thank you, Dr. Amro, for this concise presentation regarding research design. And the floor is open for any question or comment for the fellows. Any question, any comment? If there is no any question, so we can go further for the second presentation in nutrition and weight changes in all adults, presented by Dr. Akhila and Dr. Jitish. And Akhila, are you there?
Yeah, I'm there and I'm ready.
All right. Okay, go ahead. Thank you.
Okay, can everybody see the screen?
Yes. Yeah, I can see your screen.
Okay, hi everybody. And thank you, Dr. Nadir, for this opportunity. And today we're going to go through the topic of nutrition and weight. So the objectives are, we have to be able to describe the age-related changes in nutritional health. And we have to be able, like have to screen for and have to assess the nutritional status in elderly and the nutritional syndromes common in the older adults, and about the nutritional interventions for undernutrition and cultural factors that influence the nutritional care and legal and ethical issues related to nutrition. So we're going to go through these. Coming to the age-related nutritional changes, there would be changes regarding body composition, whether it being the energy requirements that change as per, our body goes through the age as we age. And the nutritional macronutrient needs and micronutrient requirements also keep changing, and the fluid needs. Coming to the changes in the body composition with the age, as we age, our bone mass decreases and lean mass decreases, and the water content in the body also decreases. And there is an increase of total body fat, especially the intra-abdominal fat stores will be increased. And volume of distribution of many medications change as the result of these shifts. And creatine-based determinations can overestimate renal clearance in older adults. And we cannot generalize well-standardized nutrient requirements of young or middle-aged adults to the older adults. Coming to the energy requirements of older adults, there's a reduced BMR in older adults, reflects the loss of lean body mass, including the muscle mass. And as we know, BMR is the principal determinant of total energy expenditure. So estimation of energy needs based on body weight is like 25 to 30 kilograms per kg per day. We have to avoid overfeeding while still meeting the basal requirements. Coming to the macronutrient needs, as per the Food and Nutrition Board of the Institute of Medicine of the National Academics, recommended a prudent diet consisting daily of protein, which is 0.8 grams per kg per day, and fat 20% to 35% of the total energy intake, with reduced cholesterol and saturated fats and trans fatty acids. Coming to the carbohydrate, it has to be around 45 to 65% of the total energy intake per day, with complex carbohydrate as the preferred fiber source. And the fiber content has to be 30 grams per day in men and 21 grams per day in women. This is a pyramid showing the the levels of all the macronutrients that are required in an elderly. And coming to the micronutrient needs, the daily recommended dietary allowances average would be around 97 to 98%. And this is a table showing the micronutrient requirements in the elderly, in females and males. Coming to the fluid needs of the older adults, normal aging is associated with decreased perception of the thirst and impaired response to serum osmolarity and reduced ability to concentrate during following fluid deprivation. Fluid needs of older adults can be met with 30 ml per kg per day, or it could be 1 ml per kilo calories ingested. A decline in fluid intake can also result from disease states that reduce mental or physical ability to recognize or express thirst, or that result in decreased access to water. And dehydration is the most common fluid electrolyte disturbance in older adults. Common causes would be decreased urine output, constipation, mucosal dryness, confusion. These are the common signs of dehydration that we see, and none of them are sensitive or specific. Coming to the nutrition screening and assessment, we have to go to the anthropometrics, nutritional intake, laboratory tests, drug nutrition interactions, and multi-item tools for nutrition screening. Anthropometric measures are often used for assessing nutrition status for the older adults, and which includes BMI, as we told. And risk threshold for low BMI is 18.5 and should be interpreted in the context of the individual's lifelong weight history. Unintended weight loss of 10 pounds in the preceding 6 months is a usual indicator of morbidity, which is a predictor of functional limitations, healthcare charges, need for hospitalization. And nutritional intake. Inadequate nutritional intake has been identified as average intake of food groups, nutrients, or energy 25 to 50% below a threshold of daily required nutrients. And poor intake is often an indication of illness. 5% to 18% of nursing home residents do not meet standards for adequate nutritional intake. Problems with obtaining food commonly contribute to the inadequate nutritional intake among the older adults, and important to ascertain whether limitations in resources or transportation or functionality may limit access to food or the ability to prepare or consume food. The laboratory test that we are supposed to do would be which are indicated for morbidity and mortality would be albumin. Hypoalbuminemia lacks sensitivity and specificity as a nutritional indicator, but the prognostic value of low albumin, that is less than 3.5 gram per deciliter, is used as a marker for injury, disease, or inflammation. Prealbumin may better reflect short-term changes in the protein status, but has largely the same limitation as albumin. Other laboratory tests include serum cholesterol. Low cholesterol levels has to be maintained. That is less than 180, and that often indicates a serious underlying disease such as malignancy. And acquired hypocholesterolemia is a non-specific feature of poor health status that is independent of nutrient or energy intake, which may reflect pro-inflammatory condition. Community dwelling other older adults with low albumin and low cholesterol have higher rates of morbidity and mortality than those with either low albumin or low cholesterol alone. And the drug nutrient interactions. Medications can modify the nutrient needs and metabolism of the older adults. Certain medications such as digoxin and phenytoin, even at therapeutic levels, can cause anorexia in older adults. Many medications are known to interfere with taste and smell, and others can reduce the availability of specific nutrients. Some medications can reduce the intake by causing inattention, dysphagia, or altered taste sensation or xerostomia. Medications that precipitate constipation can also reduce appetite. Some of the drug nutrient interactions would be, alcohol reducing the nutrient availability of B12, as we know, B12 and folate. Antacids would reduce the availability of iron, more specifically. Antibiotics would reduce the bioavailability of vitamin K. Colicin would reduce the bioavailability of vitamin B12. Digoxin would cause anorexia and would cause reduced bioavailability of zinc. Diuretics would cause reduced bioavailability of potassium, especially in magnesium and copper, zinc, B6. Isoniazid would most probably cause reduced bioavailability of B6. And laxatives would cause reduced bioavailability of calcium, especially. Levodopa would cause reduced bioavailability of B6. And coming to the other drugs, lipid binding resins would reduce the bioavailability of vitamin A, D, E, K, and metformin would decrease the bioavailability of B12. Regarding this, I want to mention a specific point. Like I've seen many cases of people on metformin and associated B12 deficiencies while I was rotating recently with another internal medicine doctor. So yeah, coming to the mineral oil, it reduces the bioavailability of vitamin A, D, E, and K. And phenytoin reduces the bioavailability of folate, especially. And salicylates would reduce the bioavailability of vitamin C and folate. Selective serotonin reuptake inhibitors would reduce, would cause anorexia. And even theophylline would cause anorexia. And trimethoprim would cause reduced bioavailability of folate. These are few of the examples of the drugs that interact with the nutritional status of the patients. Coming to the multi-item tools for nutrition screening, the Nutrition Screening Initiative has 3 interdisciplinary tools to screen for nutrition risk and help evaluate the nutrition status of the older adults. The checklist would be a 10-item self-report questionnaire, identifies risk but does not diagnose malnutrition. A level 1 screen intended for use by healthcare professional incorporates additional assessment items regarding dietary habits, functional status, living environment, and weight change, as well as measurement of height and weight. The level 2 screen for use by more highly trained medical and nutrition professionals and suggested for use in diagnosis of malnutrition. The mini nutritional assessment consists of 18 items, requires administration by a trained professional. Short form consists of 6 items, which evaluates the risk of malnutrition among frail older adults and to identify those who may benefit from early intervention. It is available as an app, for the phones and tablets. And there's a simplified nutrition assessment questionnaire which can be answered by patients through the mail or while sitting in a waiting room. The sensitivity and specificity of 88.2% sensitive and 83.5% specific for identifying those at risk of weight loss. Risk factors for poor nutritional status include alcohol or substance abuse, cognitive dysfunction, decreased exercise, depression, poor mental health, functional limitations, limited mobility and transportation, and inadequate funds, and also limited education, various medical problems or chronic diseases, and the different kinds of medications they put on, or poor dentition, and the restricted diet or poor eating habits, and social isolation. Nutritional syndromes which cause involuntary weight loss. Clinically important weight loss is a loss of 10 pounds or more than 5% of usual body weight over a period of 6 to 12 months. And a BMI less than 17 is consistent with undernutrition. Excess loss of lean body mass is associated with poor wound healing, infections, pressure sores, depressed functional ability, and mortality. Involuntary weight loss is present in approximately 13% of the older outpatients and 25 to 50% of the hospitalized older adults and more than 50% of the nursing home residents. Etiologies of involuntary weight loss would be 50% of them would be organ related, whether being congestive heart failure or COPD or end-stage renal disease or chronic infection and inflammatory states, and adverse medical effects or neurodegenerative conditions. And 20% would be because of the neoplasms, or 20% would be idiopathic, including sarcopenia associated with aging, and 10% would be psychosocial conditions. An evaluation should include careful documentation of the weights over time, detailed history including medical, dietary, and psychosocial elements, and physical examination, and focused additional testing based on history, physical, or limited standard laboratory profile, institution of treatment of the underlying cause, appropriate follow-up to assess response to management. Nutritional therapy should include dietary education, remove dietary restrictions for chronic conditions, and nutritional supplements given between meals, and a multivitamin or multimineral supplement should be included. Coming to the nutritional syndromes, that is obesity, which is defined as BMI more than 30 kilogram per meter square, which is associated with hypertension, diabetes mellitus, cardiovascular disease, obstructive sleep apnea, and osteoarthritis. Adverse outcomes include impaired functional status, increased healthcare resource use, and increased mortality. And prevalence has increased in all age groups and both the genders and all racial and ethnic groups. Treatment of the obesity would be, to achieve a more healthy way to promote improved health, function, and quality of life, and use of combination of prudent diet, behavior modification, and physical activity. For frail, obese older adults, emphasize preservation of strength and flexibility rather than weight reduction. From the NIH, age alone should not preclude weight loss treatment for older adults. A careful evaluation of potential risks and benefits in the individual patient guide should guide the management. Nutrition interventions for oral nutrition. Preventing undernutrition is much easier than treating it. So enhance food intake by catering to food preferences as much as possible, and avoiding therapeutic diets unless their clinical value is certain. And placing 2 or more patients together for meals can increase sociability and food intake, and preparing foods with appropriate consistency, attention to color, texture, temperature, and arrangement, and using herbs, spices, and hard foods helps to compensate for the loss of the sense of taste and smell, and avoiding the excessive use of salt and sugar, and avoid hard to open individual packages, and give adequate time for leisurely meals. Often decrease food intake, but overall nutritional intake increases due to nutrient quality and supplement density. And it should contain macro and micronutrients, and should be available in liquid and bar forms, such that they could carry over to any place they're traveling, and chosen based on the patient preferences and chewing ability or product cost. Current evidence does not support routine supplementation for homebound older people or well-nourished older patients in any setting. Use of micronutrient supplements is growing. Approximately 60% of the older adults take self-prescribed dietary supplements over the counter, and many vitamin and mineral supplements are commonly available in supermarket and drugstores and are generally safe except for excessive intake of such as vitamin A, D, and iron. And there's a poor to insufficient data that many nutrition supplements are beneficial. Imperative that the clinician obtain information about the patient use of all these supplements. And one of the most common vitamin deficiency would be vitamin D deficiency, which occurs in 30% of the individuals who are more than 70 years old, which is associated with impaired calcium absorption and reduced physical activity level, leading to osteoporosis. And current recommendations for all older adults include daily intake of calcium, which is 1000 mg, and vitamin D of 10 micrograms to prevent osteoporosis. And treatment for undernutrition syndromes would be no reports demonstrating improvement in long-term survival may cause serious adverse effect. And the adverse effects associated with medication used for the treatment would be metazapine causing caution with doses more than 15 milligrams due to hepatic and renal insufficiency, and cyproheptadine can cause confusion, and magestrol could increase the risk of DVT or fluid retention or congestive heart failure exacerbation. And dronabinol would lead to somnolence and dysphoria. And human growth hormone is contraindicated in cancer states and would lead to hypoglycemia and fluid retention. Anabolic steroids has no significant improvement in strength or function, and or a reduction in fractures. And coming to the culturally appropriate nutritional care, ethnic and religious customs are two of the main factors that influence food preferences. Nutrition and aging are connected inseparably because eating patterns affect progress of many chronic and degenerative diseases associated with aging. Coming to the legal and ethical issues, food and fluids should always be offered to all patients. The decision to start or discontinue artificial nutrition or hydration must be considered very carefully. Competent adults may choose to forego artificial feeding, just as they have the right to decline any invasive procedures, like do not resuscitate orders. Advance directives should be honored unless there is compelling evidence that the individual would have changed his or her mind in the current. In incompetent adults without advance directives, the decision to start or discontinue artificial feeding should be considered carefully with the surrogate. And current evidence does not support the use of feeding tubes in patients with end-stage cancer, dementia, or COPD. Palliative care, including emotional support, is extremely important at the end of life. So the summary would be the nutritional concerns affect many aspects of the health and disease in older adults. And acceptable parameters of nutritional status such as body weight and protein level should be maintained unless the patient's clinical condition demonstrates that this is not possible. There are many tools to help screen and assess for nutritional deficiencies. And cultural factors play a role in nutritional intake, as we discussed, and the decision to start or discontinue artificial nutrition should be considered very carefully. So coming to cases, so there is an 88-year-old man comes to the clinic because of unintentional weight loss over the last year. He has lived alone since his wife's death 12 years ago. He's accompanied by his son, and his son has managed his finances for the past 12 years. The patient is otherwise independent and continues to drive himself to local stores. Son says that his father is less active socially than in the past and spends most of his time watching television. Patient says that he eats and sleeps well, has no depressive symptoms, weakness, or dizziness, and has had no change in bowel movements. He has had no surgery or serious illness in the past 10 years, and he takes no medicines regularly. Colonoscopy done 2 years ago to evaluate minor hematochezia was normal. On examination, weight is 73 kgs and 14% lower than 1 year ago, and his BMI is 23. And the remaining examination findings are normal. Fecal glyc is negative for blood, and score for MMSE is 28/30, and the patient health questionnaire score is 0. And laboratory findings shows normal urine analysis, and CBC electrolyte levels are normal liver, kidney, and thyroid function. chest X-ray is normal and EKG shows normal sinus rhythm. Which of the following diagnostic evaluation is now indicated for this patient? You can put in your answers in the chat. Yeah, as most of the people said, it's like no further diagnostic testing is required. Because involuntary weight loss in older adults is always a cause for concern. It is often a harbinger of the subsequent adverse clinical events, including death. The risk of death increases in direct proportion to the amount and the rate of weight loss. As a general rule, loss of more than 5% of the body weight within 1 month or more than 10% in 6 months should prompt a careful evaluation. However, even lesser amounts of weight loss may be clinically significant, and it depends on each individual. Coming to the next case, an 81-year-old woman was admitted to the hospital 3 days ago because of hypotension, depressed sensorium, and urosepsis. 5 weeks ago, she had perforated gastric ulcer and sepsis. Her postoperative course necessitated prolonged stay in hospital and nursing facility. In the current hospital stay, she responded to IV fluids and antibiotics and is now alert and cooperative. For the last 2 days, she has been on regular diet with polymeric oral nutritional supplements between meals. Nurse notes indicate that her nutritional consumption ranges from 25 to 75% of the meals. On examination, her weight is 142 pounds, and which has come down from 152 pounds within the past 3 months, and her BMI is 21.6. And there is a non-inflamed surgical wound which is being allowed to heal by the secondary intent. There is 4+ pretibial thigh and presacral edema, and the serum albumin is 2.7. So based on this, which of the following is the best option at the spine to determine the patient's need for additional nutritional support?
Could we just see the options again?
Yeah, sure. Okay, so the answer is C, not A. You have to order calorie count for 3 days, because it is really crucial to know how well this patient is eating, and the combination of bed rest and acute disease-induced inflammation and anorexia can result in rapid loss of both lean tissue mass and body stores in older patients. So, yeah. Moving on to the next question. A 69-year-old man is transferred to the medical unit after spending 6 weeks in the ICU for ventilator support related to post-influenza pneumonia and acute respiratory failure. PEG tube was placed 4 days ago before transfer to the medical unit. And patient was started on polymeric feeding solution at full
We lost your voice. If you can check that.
Sheila? Yeah.
She's cut off.
We can't hear you, Sheila. Hila, please check your mic. Hello, Hila. Dr. Nadir, I think you are muted.
All right, sorry. So I'm gonna take from here. So basically, the patient was admitted to ICU with pneumonia and for 6 weeks, and he came out to the floor with peg tube and started on tube feeding. He has history of no history of CD, but he had diarrhea. No medication that can cause diarrhea. Before he was hospitalized, his weight was 72 kilograms and BMI 23. So here's the findings on exam and laboratory test. So his albumin is kind of low. The albumin is normal, but on the low end. Sodium, BUN, and the rest seems to be okay. So if we go to the findings from liquid stool samples, he has negative CD and the other genes. So a swallow evaluation was ordered. So the question is, which one of the following should be done next? You prescribe anti-diarrhea like loperamide, or you start total parenteral nutrition, or you start dysphagia diet with hand feeding, or refer to a different tube, which is digenostomy tube. So you can send your in the chat your answers. So some says B, one C, B, some say B. So between B and B, the answer is A for this patient. So basically, you want to make sure no cause for the diarrhea that you can identify. Let's say C. diff, you can treat with some antibiotics, or some medication can cause diarrhea, so you stop or you remove them or switch them. So the idea is to try to minimize any risk factor for diarrhea. But this question refer you to the side effects of artificial or tube feeding. One of the side effects is it can cause diarrhea. So when you investigate other causes and you make sure there is none, then you will end the tube feeding, and then you will prescribe some loperamide. Okay, and I think that's it for this session. And Akira is back, so
yeah, sorry
so
about
take it from there. No,
I
no
had a
worries.
poor connection.
That's all right.
Thank you, Dr. Nader.
You're welcome. Did I miss anything, or you want to add anything?
Yeah, I think we're good. Like, if anybody has any questions, yeah, you can just go ahead. Other than that, I think we're good.
But thank you so much, Akira and Amber, for great, excellent presentation, both of you. So, any comments, any questions? We have we lost Dr. Mayada, and she's a dentist, and I think there is another dentist with us. mentally. So any comments from any or from you? Or? So it's important to evaluate the patient from head to toe, but mostly we focus on also on the oral and if they have thrush, if they have dental problems, we want to modify the diet for them. So at least when we see them in nursing homes, we have a dietitian, we have a speech therapist, and both will work together as a team to address the feed intake and nutritional. Because we want to make sure if they have, let's say, pressure ulcer, the healing process will take place. Thank you both. If ready, we can go to the next session. Or,
Thank you, Dr. Akhila, for this great presentation. And we can go further for the next presentation. We have two other presentation, dentition in older adult, and presentation on poster preparation and presentation. So if Bushami is ready, he can go ahead, or if Sahar is ready, she can go ahead for her presentation. I don't think, I didn't see Sahar. So Bushami, if you are ready, you can go for poster preparation and presentation. Bushami?
Hello. Yeah, hi, Dr. Osama. Hi, Dr. Nadir. I am ready with my presentation, but I had an issue in joining with, so I'm joining through my phone and I have my poster presentation on my laptop, so I'll not be able to share it, the slides. Will that be okay?
Send it to me, I can share it. You can send it by email. Or...
Yeah, sure. Just a second, doctor.
Dr. Akhila, would you please lead the meeting because I need to go?
Yeah, sure, Dr. Osama. I can do that for you.
Yeah, Dr. Nadir, I have to go to
so much. Yeah. No worries. Thank you so much, Dr. Osama, and have a wonderful day.
You too.
Bye.
Dr. Nadir, I just forwarded the...
It's coming. It's the weekend, so it will take longer. Did you send it to Nadia at MSU or Nadia?
Yeah, I sent it to nadir@msu.edu.
It's just coming. So you can start if you want to just talk, and when I get the file, I will share it.
Should I start it, doctor? Or...
Yes, you can start, and as soon as I get, so the email you sent to nadir@msu.edu, is that correct?
Yeah.
Okay, so it's gonna be somewhere here.
Hello, everyone. This is Pushyami Satyabandi from Blue Team. My topic is poster preparation and presentation. So first of all, what are the posters? Posters are a legitimate and popular presentation format for research and clinical vignettes. They efficiently communicate concepts and data to an audience using a combination of visuals and text. So poster presentations allow the author to meet and speak informally with interested viewers, facilitating a greater exchange of ideas and networking. Poster presentation offers the first opportunities for young investigators to present their work at important scientific meetings and preparations for the publication in a peer-reviewed journal. What are the prerequisites for the poster preparation? First, you must have a desire to be effective and be willing to put the time for the product design and production of the poster. Second, you need organization skills. Because posters are associated with more deadlines than oral presentations, we need a proper necessary interaction with graphic artists as well as production and the needs of the meeting. These all need a organization skills. So first, we need to determine if your poster will be judged at the scientific meeting. If so, we have to go for the judging criteria, which will be helpful for you to plan and construct the poster. So first, we need to know the judging criteria based on the type of poster we will be presenting. Then know the rules. It is your responsibility to know the physical requirements for the poster, including acceptable size and how it will be displayed. All scientific programs that sponsor a poster session will send you information on the display requirements at the time your poster is accepted for the presentation. So we need to review and follow the instructions precisely. General abstract competition poster guidelines. Each presenter will be asked to give a 4-minute presentation overview of their research or their case, leaving 6 minutes for a question and answer session with the judges. The poster board surface is approximately 4 inches high and 8 inches wide. It has a cork base with fabric covering so that either push pins or Velcro can be used. You need to prepare a panel indicating title and authors for the top of your poster space. The lettering for this section should not be less than 1 inch high. You are asked to make no major alterations in the text of your abstract. Research posters should include a copy of abstract typed in a large font and posted in the upper left-hand corner of the poster board. All illustrations should be made beforehand. We have to bear in mind that your graphics may be viewed or read from distance of about 3 inches or more, 3 feet or more. Charts, drawings, and illustrations might well be similar to those you would use in making slides, preferably simple and more heavily drawn. They should not be arty. Simple use of color can add emphasis effectively. Do not mount your poster on heavy board because these may be difficult to keep in position on the poster boards. Hand lettered materials should contain appropriately heavy lettering at least 3 by 8 inches high and shade block letters where possible. Finally, keep illustrative material simple. And once you know the rules and we have to determine exactly how the poster will be produced. Make sure you have your deadlines, include sufficient time to revise the poster. If you find mistakes or otherwise need to make changes prior to the scientific meeting. If you are working with a graphic artist, make your timetable after consultation with him and be realistic and understand your time constraints. Compile a list of components that will appear on the poster. There are common elements to all posters, whether they are research presentations or clinical vignettes. At the top center, the posters should display the title, authors, and institutional affiliations. Any necessary acknowledgements can also be placed here. Many scientific programs will insist that the abstract be included on the poster and will specify its location, that is upper right corner. Coming to what are the types of posters we can make. So there is scientific posters. While preparing a scientific posture, we should follow the IMRAD format, that is introduction, methods, results, and discussion. Introduction presents the background and the purpose of the research. Background information typically consists of a statement summarizing the current knowledge in an area, what knowledge is missing, and how this research project addresses the knowledge gap. Hypothesis can be included in the introduction. Then coming to methods section should specifically address the following areas: research design, research setting, number of patients enrolled in the study, and how they were selected. The methods section should also include a description of the intervention. If appropriate, a description of outcome variables and how they were measured, and the method of statistical analysis. Results. Results section includes the quantitative data. This section usually begins with a description of the subjects in the study and the description of those who are not included because they failed to meet the inclusion criteria or dropped out. Include the frequencies of the most important outcome variables. Consider comparisons of the outcome variables between various subgroups within the study, that is treated versus untreated, young versus old, male versus female, and so forth. Numerical results should include the standard deviations or 95% confidence limits, and the level of statistical significance should be indicated. Finally, in the discussion section, state concisely what can be concluded from the study and its implications. Make sure that the conclusions are supported by the data presented in the results and do not present unsubstantiated personal opinion. This is a template example of the scientific posture where you can see introduction, methods and materials, results with the discussion and conclusions. References were added in the end. It should be simple and given in a detailed way. Coming to clinical vignette postures. Clinical vignette postures generally have three components, which is introduction, case description, and discussion. Short introduction typically describes the context of the case and explains its relevance and importance. When describing the case, follow the basic rules of medical communication by describing in sequence the history, physical examination, investigative studies, and patient's progress and outcome. Main purpose of the discussion is to review why decisions were made and to extract the lesson from the case. Keep in mind that the best research and clinical vignette postures are those that make a small number of points, even just one, clearly and succinctly. Clinical vignettes offer an excellent opportunity to display clinical photographs that illustrate important points of pattern recognition. This is the example of the clinical vignette posture where you can see introduction, the case description, and the images related to it, and the discussion. Tips to keep in mind while presenting a posture. We need to avoid clutter. Limit your posture presentation to few main ideas. It's better to present a few of your findings than present all of your findings poorly. Arrange your posture components to read from left to right and top to bottom. Emphasize important points on the posture with lines, frames, or boxes and arrows. Keep the lettering simple. Use no more than 3 different font sizes. The largest for the posture title, second largest for the section titles, and smallest for text. For all lettering, use both upper and lowercase letters. Words composed of all uppercase letters are difficult to read. Smallest font should be large enough so it is easily read from a distance of 3 to 5 feet, usually 24-point font. Keep the colors simple. Too much color can be distracting, while too little color can be boring and lifeless. Use color mainly to highlight the important elements. Coming to last minute workup. First, it's our responsibility to review the first draft or copy of the posture. This is the best chance to correct the errors and make changes to improve the accuracy and visual attractiveness of the posture. It's best to have a colleague help you to proofread. It's a good idea to have someone unfamiliar with the research or case help you, because he or she will quickly identify areas that are confusing or ambiguous. It's a good idea to have someone who is expert in spelling and grammar review the posture as well. As mentioned previously, schedule the proofreading early enough in the process so that you have time to make any corrections or changes prior to the meeting. And finally, keep a posture checklist where you can have all the workup done and make a checklist ready. This is an example of the posture checklist where you can see divided into content and appearance. In the content, we have titles, authors, and institutional affiliations for research postures, for clinical vignettes, and logical sequence of the information. Photographs, tables, charts are used whenever possible to display data or convey important information, and each section is concise and clear. Then for the appearance, poster meeting the size restrictions of the scientific program. Poster construction will accommodate the method of display at the meeting, that is pinned, hung, easel, and taped. Abstract is posted in the proper position on the poster. The poster does not appear to be cluttered. Major headings can be read from 3 to 5 feet away. Text and figures can be read from 2 to 3 feet away. Graphs and figures can be read from 2 to 3 feet away. Font is similar throughout, no more than 3 font size used for poster title, section title, and text. Color, lines, boxes, and arrows are used to emphasize the important points. Once we are done with this, we know we are done with the poster preparation and how to present. First, we need to be welcoming. We have to think of a poster as a conversation starter. Smile and say hello to everyone who walks past and looks at you or your poster. It's important to engage your audience. We have to remember to be enthusiastic and make sure your pitch is punchy, intriguing, and relevant. Practice is a major factor in success, so rehearse what you will say and practice presenting on your friends and family. After the presentation, check with the audience understanding. Ask the members of the audience whether you have been clear or if you should go into more detail. Dress for the occasion. And finally, the handout. The handout is important with important details like what is the purpose of your poster, what are you hoping to achieve with your presentation, will it enhance your audience engagement with your research or not. Look for the opportunities to engage, contact information. If someone is particularly interested in your poster and wants to know all the details of your research, it may be better to suggest meeting them for a coffee after the poster session or arranging another time for further discussions. And finally, an important thing is to deal with the feedback. It is important to welcome feedback, be prepared for the discussion, and not to be too defensive in the face of criticism. Thank you.
Thank you so much, Shima. This is a very great, excellent presentation and concise and to the point. Any comments or any questions, Shima?
Thank you, Dr. Nadir.
So basically, you will be printing in the past the poster and hang it on a wall, and then people will come and look at your presentation of your poster and your presentation of your study. And sometimes you will have a judge who will come, sometimes one person or more than one, and they have a list of items that they check. Is the concept of the poster or the idea of the research new, for instance? Is it innovative? Is it important to the public or something like that? So they have a list of checklists. Then they will see your presentation, like how you are able to present with clear voice, something like that. So they have their own checklist, and at the end they will identify what the best presenter and what the best topic and the whole design of the poster. And in certain conferences, they will give prizes for the first or second or third presenter. That goes for poster presentation and also for oral presentation. So basically, you will be ready when you print and hand the poster during the session. So if Ala with us, maybe Ala, can you give us your experience? Because Dr. Ala has and her team has developed this project and finished it and submitted, and the abstract was accepted as a poster. So they worked on printing it, and she went and attended the meeting and presented the poster. Can you share, Dr. Ala, if you're there?
Yes, sure. Hi, everyone. I hope you're all doing well. Yes, regarding my poster presentations in Ohio, Cincinnati, it's really amazing. It was really amazing experience, to be honest. And thank you, Dr. Nader, to give me this opportunity. And actually I have a small present PowerPoint I would like to share with the group.
Okay.
So that's how we can discuss my trips all from the beginning. So yes, actually I went to the USASP annual scientific meeting where I present the role of the non-pharmacological pain management in nursing home residents during the pandemic. So I will start from the beginning, like the preparations of my poster. After my poster was accepted, we worked with the group to prepare our posters. And before my flight, I downloaded the Cisco app as it's used by conference coordination to facilitate the communications between the trainee. And also it's contained the agenda of the meeting and also the map to guide you to where you will go exactly. And also I printed my poster in FedEx according to the requested dimension. In the FedEx, they usually provide you with the hard case to secure your poster. So I landed in Cincinnati Airport at 5 p.m. and it was raining heavily, actually. And I realized it's near to North Kentucky, which is the people there were very friendly and nice. And after that, I went to hotel, which is located 5 minutes away from the conference room. And the good thing that in early morning, when I was going to same conference, we met actually people who are going to the same conference. So we went together as a group at that time, which is give me a sense of security there. And coming to the conference itself, it happened in Cincinnati University, the main campus. And it's really a big and huge university. But in the same time, the event was well established and organized and easy to navigate through or using this Cisco app that they provided by the meeting. And also there is many signs to facilitate the directions. So I didn't find any difficulties to find the locations or where to go. So first thing I did when I reached there, I was starting by the registration where you can take your badge and notebook and pen. And also there was many people from different specialties like MD, program director, such as the NIH research director. And also there is a fellows and many people have a PhD in research, so they are heavily researcher. And also there is a student. So, and also they coming from the global, it's not only from the United States. it's amazing actually to see all these people who have, the same interest, which is the pain. And so I like actually the diversity and the hierarchy during the conference. And also there is a job fair with the opportunity to conduct the meeting or the interview on site. I think I'm taking a long time, talking a lot. So I will try to summarize, sorry.
So that's fine. Go ahead. No worries.
So, before, actually before one night, like short notice, they asked me to another 2 poster to present as a speaker because it's included the clinical, this is the only 3 poster included the clinical research. Most of the poster, they are related to the basic science and have done in rats and mouses. So we are the only 3 posters. So they asked us to present in the Great Hall. I'm trying to move this. Okay, yeah, this is the hotel. I forget. This is when I reached the hotel here. Yes, it's very good. Yeah, this is the Great Hall where the speaker can present. So you can imagine every time you move. So regarding the poster canvas was in the conference glass room with the Cincinnati University stadium view. Let's see this actually. That's here. You can see this is where each one can put the posters and actually it was from each, there is many university, and thank you Dr. Nadir actually to give us this opportunity to participate and represent actually the MSU. So. Okay, I'll stop here. So, like at 3 p.m., I hanged my poster and the people started to come, and I presented my poster many times actually through this 1.5 hour with an engagement. And the judges were impressed actually with the topic and the idea of treat it as a human instead of, concentrate in the medication. And it was really long day till 8:30 p.m. And also I went again the next day, but only half day as my flight, it wasn't 6:30, so I have to leave and to the airport. So in summary, it was really unique experience for me. And personally, I encourage each fellows to try this experience. It will really improve your confidence, and also it will build your connections and foster your application. For me, actually, despite my exam is near and I am going through many stress, and this trip de-stress me really, and really I enjoy every moment in this trip. And thank you, Dr. Nadir, for this opportunity again. And yes, this is the poster where I hang it. And this is me where when I presented. Thank you.
Thank you so much, Dr. Ala. This is a really great and concise to the point, and thank you for sharing your experience, and I'm very glad that you enjoyed it. So basically, it's when you go to the conferences, people use it as a network, like you make connections, and you also know what other people are doing, what other research groups, new ideas, and you can collaborate in new projects. and so forth. So there are a lot of benefits of going in person to this meeting. So I'm very glad that Ala went and presented. Thank you so much for doing that. I know you are preparing for step 3, but hopefully this will be a good memory for you, and hopefully it will help you in the future as well. Great. And I'm very glad that we are one of the 3 posters about the human in this research conference. It's great. So maybe we can work on joining them next year, and then we will try to present in this conference in the future.
Yes, sure. Thank you.
Thank you so much for sharing. And last, I think, month or the month before, Dr. Selma also mentioned or presented similar presentation in California. So she went in person and put the poster and presented that. That was a great one. So Mahal, Dr. Mahal, please go ahead. She is one of the new fellows. Introduce yourself and go ahead with your comment or question.
Okay, I would like to introduce myself. So, hi, and I would like to thank Dr. Nadir for the great opportunity. My name is Minhal. I'm a dentist. I graduated from University of Science and Technology, Sudan, and I am a graduate student on public health program on East Carolina University. I should be graduated by this fall semester, inshallah. And I'm so glad to be part of this team, and I'm looking forward to working with you, all of you. Thank you.
Thank you, and welcome on board. Thank you. Someone else raised their hand or has a question or comment? Akhila, if you want to add? If not, we can go to the next section. But before we do that, so in the last 2 years or 3 years, we got the COVID, so the most of the conferences and the meetings were held online. So we participated in different conferences online. So it's a little bit different compared to in person when you have a poster that you want to present. So some of the conferences will ask you to submit the poster in like just one page PDF file or PowerPoint file, only the picture, similar to what printed out. It's gonna be just this in PDF or format, and you can share that with the conference. Some will ask you to put a video, like a 3, 4, 5 minute video. So you will go the same poster, and then you will present each section of the poster, like you go over the introduction, the method, the results, and then the conclusion of what you got out of this study or research project, and what the future direction. So this is what happened in some of the presentations of this fellowship in the past. So I'd like to thank all the fellows, current and previous fellows, who work hard to make this happen. So we'll go to the next. If
Okay,
you have any, yes, please go ahead.
No, I just want to, go on to the next person who want to present. So I just want to announce that. So yeah, go ahead. Sorry to cut you off.
That's fine. If Sahar with us, not sure if.
Yeah, Sahar. Yeah. The next topic would be dentition in the older adults. Presenter would be Sahar. If you are ready, we can go ahead.
I don't see her name on the participants here. Sahar, are you with us? Sometimes people join with their phone or they don't put their name. If not, that's fine. So I don't see Sahar. Maybe she has technical issues or other reasons. But basically, we want her to talk about just a little bit of the dental concerns or issues when we get older that dentists will see in their practice. Maybe Manhal or maybe Mayada or any dentist with us. Maybe they can share what do they see when they encounter older others. Mostly what I was referring to maybe dentures. So sometimes we use our teeth for one reason or another, and we use artificial teeth and dentures. So some of them might have also some problems when you put them on for a long time. They may have like they are not fitting well, or they can cause pain, ulcers, or they are not working the way supposed to. And this can cause more problems than solving the issue of teeth there. So, Manhal or Mayara, you want to give a little bit of comment there? Go ahead. I'll put Mayara. Manhal, how about you?
I was away from a second. I didn't hear what did. Can you please
That's all right.
repeat? Can you please repeat what you said? I'm so sorry for that.
No worries. So what we were planning to do, we had 3 dentists in this fellowship. One of them is Dr. Sahar, and for some reason she couldn't participate for, I don't know, technical issue or other reasons. But basically, we want to talk about all the adults and the dental conditions or encounter when you see an older adults, what the major problems that you see them for and how you treat them. Because we are talking about nutrition, and this is an important part also.
Oh yeah, that's very interesting. Yeah, there's many issues that face the elderly, like as we know, with age, people will suffer like from like chronic diseases like diabetes, and that can affect like the jaw bones, and that can lead to tooth loss. And usually they face like a big problem, like if they want to like do like prosthesis, like artificial teeth. And also due to the regression that's have happened to their, like the recession that's happened to their gums. And also the muscle become weaker, and there that things make the process very complicated. So we can discuss these topics, like if the like Sahara Mayada, like we can make a group and try to like make interesting topics about elderly and dental complications. that would be great.
I think it's a good idea. Thank you so much, Dr. Manali, for
Sorry, Dr. Nader. Hello.
Yeah. Hello.
I have technical issue with my mic. Sorry, I'm so sorry.
That's all right. That's all right. That's okay. Things happen.
Yeah, just I wanted to add beside Dr. Manhal. Hello, Dr. Manhal. Welcome.
Hi, Dr. Maya. Thank you.
She beside what she mentioned, I would like to add sleep disorders and sleep apnea with the elderly. As people getting older, the oropharyngeal space become longer and they suffer a lot from sleeping. Especially beside the rheumatoid and TMJ disorders. All this disease are affecting elderly. I think, Dr. Manhal, she covered all the topics. I'm willing to do a WhatsApp group and discuss all that, Dr. Manhal, for sure.
Excellent. So maybe we can plan ahead as far as we can have more topics on this area presented in the future by the dental fellows. Okay. Excellent. Thank you so much, both of you, and thanks to all presenters from today. So we can go to the next excuse me, item, and we can talk about other research projects or ideas. Anyone wants to share their ideas? In the past few weeks, we were talking about some ideas, and what I think is I want to open the floor for you guys to see what area you are interested in or areas, and if you have an idea, and you can make it as a project, and then you can take it from there. Any input from you guys or any projects? Sometimes it's hard to have the yes. Go ahead, question.
How are the topics related to the artificial intelligence? There are quite a research going on that side, like using the machine learning or to learn the probiotic sequence. I am a member of that kind of paper, but I'm seeing whether in future those papers are needed.
Definitely, I think this is a great area for us to investigate and see what we can find out or contribute to. So by all means, if you have an idea specifically in this area, you can work on getting it. So in the past, we published about COVID and artificial intelligence, but we did not go further the next step. So what we said, we can build up some tools that hospital can use for stratifying or dividing patients when they come to the hospital according to certain criteria where they will end up and like prognosis, something like that. But it's interesting area. Thank you so much.
Okay. Thank you, Doctor.
You're welcome. Any other ideas? So my thinking is we can look at certain conferences. Let's say I'm interested in neurology, applying to neurology. So I will go to the neurology major journals and see if they have abstracts for their annual meetings. So the American Neurology Association or something like that, they have their own journal. I will look at that journal and look at what they did in the past few meetings, last meetings, let's say 2021, 2020, and see what the major areas of interest for them. Sometimes we can modify what they presented. So if they presented certain topic in a certain population or certain area, then we can look at the same method, and we apply it to a different, if they say, look at people in Michigan, then we can apply the same concept in people in Florida, for example, or in Europe, for example, if you are there. Or different age groups, or let's say they look at COVID in adults, we can look at COVID in older adults as far as regarding neurological symptoms or perhaps atypical symptoms of presentation, something like that. So this is one way to look at what previous people did and what's in the literature, and how we can modify that and how we can come up with new data and publish that. The other way is to look at previous work 10 years back, like in 2010, 2012. Some people mentioned or presented certain posters or papers. We can look at that and we can say 10 years back or 10 years later, what happened, what different. Yesterday I was looking at the app, for example, older adults and the use of the phones. So the smartphones have been here for several years now. So in 2012, 2014, they did some studies about how they use it for, let's say, health in older adults. So we can look at that and compare it nowadays. And we can look at the picture and then see 10 years difference between what people thought about using the mobile phones and software or app in their health, for instance, and then how can we modify that or encourage that or use that in clinics, for instance, to help patients in their home and so forth. So it's kind of an education part, but at the same time, you can use different aspects, like we can look at the usability. We can look at the app itself. Let's say we focus on blood pressure medication or monitoring or tracking apps. How are they designed? Let's say, are they designed well for people with vision impairment, let's say, or arthritis, something like that? Or can we modify this so that it can accommodate all the others? Because we should think about the whole person. It's not about the technology itself, something like that. So these some ideas about how we can start some of the project. One idea is how these social media issues, let's say YouTube, when here in the US, they use Facebook, for example, spreading misinformation about the vaccine when the vaccine came up. We can look at the use of YouTube videos in this area, the COVID vaccine, whether it's good information or misinformation. And we can limit that into all the others. So we can review the videos that are published in the year 2020 to 2022 and see how many of them are good, how many are bad, and how we can encourage or try to advance the use of good information and good social networking of tools or platforms that can be used for all the others, something like that. So we can think about anything that's innovative and doable online. You don't have to be specific to patients. Like you look at the chart and the old way of doing research as we are connected virtually nowadays. So if you have access to charts, that's fine. If you have access to clinic or hospitals where you can get information from patients and look at that, that's well and good. But also think about options where you can do research without going into difficulty as far as time spending or going through IRB and so forth. So Any comments, any questions?
Dr. Nadir,
Yes, correct.
so if we have access to the patient, is it good to do like cross-sectional study, or I'm like doing scales and assessing the assessments? Based on that, can we do a topic, or will it be?
Oh, definitely we can do any type of research. It depends on what's your research question. Let's say you are thinking about patient with MS and all the others, let's say, and it's a good area. The second question will be, did they address this in the literature? Did someone do the same idea that you are thinking about? If anyone has published something like that, can you modify whatever in the literature? Or you already answered the question that you want to raise? If they already looked at the variables of the chart and they come up with answers to your question, then I don't think you will go that area. If it's not answered before, then think about your design, your variables, and you can start. The only concern for me is how you can get the information from the chart. You have to go through IRB approval. Sometimes this may take longer. In our case, it took shorter time here in Michigan, in Nancy. We work with the hospital and their IRB and NSA, the Michigan State IRB, and both of them, they work together. So it was fast track. We did not obtain a lot of identifiable information for our research in the past 2 years. So that worked for us. So if you think about doing it, go ahead and we can talk about that in detail on the side. Just shoot me an email. Thank you.
Okay. Thank you.
Any other questions or any other comments? And if you have any questions.
I have an interest in histopathology, and I saw in the tele-rotation website there is a prostate histopathology research was not accepted, and in the notes they mentioned they want to re-edit the abstract and to be admitted again some conference.
Yeah, so if anyone else interested in pathology, for instance, maybe Joseph and these who are interested, we can work on revising that poster. So basically, we have some data collected, I think, in Sudan, and we wrote the abstract, we submitted it, but they did not accept it for that conference specifically. So we can modify, or we can get maybe more information, or look at the literature and see if the question was answered or not. So Joseph, shoot me an email, and then we can work on getting that. Maybe we can resubmit it to either the same conference or different conference. So the experience we have, like Dr. Ala and her team, worked on the PEN project in nursing homes. We submitted to a conference and they did not accept that. So they rejected it. We worked on it again and we submitted to a different conference and they accepted it. And thanks to Ala and her team, we presented that in Ohio. Okay.
Thank you.
You're welcome. Good question. Any other questions? So if no other comments or questions, we can think about next week, prepare for next week topics. If the person are with us, I'm gonna just share the screen for you guys. So basically, the technical team will be presenting some of the topics. I'm putting names here. If any one of these names are not available or they have other applications, they can switch their names. So maybe you can reach the persona and explain or not explain, but discuss other options. So if, for instance, someone wants to talk about certain topic, we can add it here. So the first topic, we will talk about schizophrenia and psychotic disorders. And if you scroll down, so when you go to the ad, for instance, the home page, we go down to upcoming Zoom meetings. You click on it, and next week will be the careful team. These are the topics. We can edit these topics. You can remove your name or you can add your name if you want to discuss. So maybe I put Sarah, Tracy, and Bertrand to work together on this topic. For them, the topic is already here, the slide. We have teaching slides from the American Geriatric Society. So they can just download these teaching slides and they can go over it, or they can update it if there is more information. These slides, I think, made 2 years ago or something. So maybe there is new information. The second topic, maybe we can talk about research bias. I put Dr. Shah and Shaina. If anyone else wants to jump in this group, maybe they can join. And the last topic here, the third one, I want someone to talk about synthetic pharmaceuticals. I put Arij and Sarah. If they are busy, maybe another two they can work on this. And also with VRS slides, which is teaching slides. The other way to find more files, if you go to the three dots and go down, you will find some of the files here, and you can look up here. So you will find some of the topics here as well. So I think I have slides. So these are all the files that we have, or maybe you can select some of the topics in the future as well. If you want to work on your presentation skills, you can download any of these and you can just practice presenting, and then maybe in the future you can present some of the topics. So any questions or any suggestions, any comments? I know I talk a lot, so I will keep you here for favor if you give me, and then if you give me to talk. So better comment or ask. All right, Sarah Shafia, go ahead, Sarah.
Yes. So you're talking about the GRS slides. Are they ready made, or like we need to make a new one from the beginning?
So they are already made, like the presenter from today's topic. One of them was already Akhila presented from slides that are already made. So it's an option for you to download the file. It's PowerPoint presentation, so you can just go over it and see. If you want to present the whole thing, that's fine. If you want to modify it, the colors, maybe you don't like the blue colors, you can change whatever. If you have more information, let's say you want to get an updated information to certain slides where the information might be too old or maybe wrong information by now, you can modify that as well. So in the past, like 20, 30, 40 years ago, they were teaching that congestive heart failure patients, we are not supposed to give beta blocker. So they did more research and to switch that. So nowadays, it's recommended that patients with congestive heart failure, you can give beta blocker. So maybe in the future, we will have some information updated So if you have time to update the information on the slides, that's well and good. If you want just to present it, you can use that slide file and you can present it. If you don't find it on the app, shoot me an email and send you a copy.
Yeah, I don't see Syncope right now on the app
I
for
will send you
GR.
a copy. I will
Yeah.
send you a copy.
Okay, thank you.
Okay,
You're welcome.
I sent.
All right. I will send both of you. Any other questions? Any other comments, suggestions? If not, then I'd like to thank you all the presenters, all the fellows who are presenting or attending this meeting. Thank you so much, and I wish you all the best. Good luck. Have a good day. Have a good night. Whatever. We'll see you next week, and have a good day. Thank you.
Thank you.
Thank you, Dr.
Thank you,
Nader.
Doctor.
Everybody.
Thank you,
Thank
Doctor.
you. Thank you,
Have a
everyone.
great weekend, everyone. Bye.
Thank you,
Yeah.
Dr. Nader. Thank you, everyone.
Thank you, Dr. Nader.
Have a good day.
Thank you, Dr. Nadir.
Thank you. Bye-bye.
Thank you, Dr. Nadir.
Thank you.
Thank you so much. Thank you, guys.
Thank you so much. Have a beautiful day.
Wonderful day.
Thank you, Dr. Nadir. Have a good
Thank
day.
you so much once again. Have a good day. Thank you.
Thank you so much.
You're welcome. Thanks. Bafran, if you're there.
Thank you, Dr. Nadir. Have a great weekend.
Thank you. Thank you. Thank you.